So, coming to the next part, fluid balance and fluid therapy. Body fluids are predominantly composed of water, ions, proteins. The movement of fluid within the body across the capillaries depend on relative concentration of three components. Water is there, ions and proteins. These three components are important. Different concentration of the components exert forces across cell membrane. The net movement of fluid depends on the balance of these forces. What is this? What are the forces? That is osmotic pressure and hydrostatic pressure. So, composition of the body fluid: water makes up 60% of the man, 50% of the woman, and 75% of the child. So, this is 60, 50, 75. Men, women, child. New thing, and the formula of 60 is the majority of water body is from the oral intake. The addition of a small volume is produced with oxidation of the hydrogen. Total body water is total body water volume. Is total volume of water. Extracellular fluid outside the cells, intracellular inside the cells. Total body water minus extracellular fluid is intracellular fluid. Plasma is blood without cells containing proteins, water, electrolyte. Transcellular fluid is defined as being separated by the layer of epithelial material, cerebrospinal fluid, intraocular fluid, synovial, digestive secretions, gut lumens. Volume is relatively small. If transcellular component is very large, it may be called as third space. So third space, this is something called third space. What is that? Cerebrospinal fluid, intraocular fluid, pleural fluid, synovial, digestive secretion, gut luminal fluid, or there can be the transcellular component is very large, because fluid in this component is not readily exchangeable with the rest of extracellular fluid. Intravascular volume is fluid within the vascular compartment. Interstitial fluid, cells within the tissue. So intracellular, extracellular, and transcellular, you can see. So ECS, intracellular, extracellular fluid, is also called as vascular compartment. So roughly it is formula of 60, 40, 20, 15, 5. This is plasma. This is intracellular, and this is interstitial. Total body water, 70 kg man, water is 45, that is 60%. So one third is extracellular, means roughly 15% is, out of which suppose it is 5%, 3 plasma, interstitial lymph is there. Again interstitial plasma is divided into lymph and plasma, transcellular fluid. 2/3 is intracellular, so this is ICF, and 1/3 is extracellular. Then this is again divided into intracellular. So transcellular fluid, 2/3 is intracellular fluid found in cytoplasm. Extracellular fluid, intracellular fluid, total body. These are the two important things. And third space is volume is transcellular compartment is very large. It may be third space fluid because component is very not exchangeable with the extracellular fluid. Distribution of ions in the body: extracellular fluid, intracellular fluid. Maximum outside are sodium, inside are potassium. So this is just like extracellular fluid means plasma 135 to 145, 3.5 to 5 potassium, calcium, ionized calcium total means bonded with the proteins is total. Magnesium, bicarbonates, chloride, phosphates are intracellular. Potassium is intracellular. Magnesium is intracellular. Protein intracellular is very high. Potassium, magnesium are the main cations. cations. Positive are called as cations. Phosphate, protein, and organic ions are anions. Now ECF has got sodium ECF, main cation, and anion is chloride bicarbonate. How is the regulation of potassium? Mainly intracellular level inside the cell are maintained by sodium potassium ATPase pump. This is active transport. Plasma levels of potassium are tightly regulated because of hypokalemia, hyperkalemia, main effects of cardiac abnormality. So it is the control of potassium in the levels in plasma. Potassium plasma is controlled by dietary food, banana, chocolate, avocado, fake streams, tomatoes, renal excretion, sodium, resorption of sodium and collecting duct depends on the exchange of potassium. This is controlled by aldosterone. So collecting duct, this is the question. This is the question, active transport. Aldosterone may also produce in response to high potassium levels. So excretion, it helps. Plasma pH, hydrogen ions move in and out of the cells in exchange of potassium ions. When hydrogen levels in the plasma rises, hydrogen enters the cells in exchange of potassium, thus raising the plasma potassium levels. So whenever there is retention of acidosis, potassium cells are, hydrogen levels in the plasma falls, hydrogen ion leaves the cell exchange of potassium, lowering the plasma levels. In addition, main attempt to hydrogen ions is alkalic state. So insulin, this is important. Insulin, adrenaline, aldosterone stimulates cellular uptake of potassium. Insulin, cellular uptake. It shifts from plasma. Whenever there is hyperkalemia, you give the insulin, it shifts from plasma to the cells. Drugs that affect potassium levels in the body, drugs that increase potassium, increase potassium. Potassium is increased by angiotensin convertase in 9. ACE inhibitors, antihypertensive which use, then cyclosporine, angiotensin 2 receptor antagonist. Potassium salts that increases. Drugs that decrease potassium, loop diuretics, thiazide diuretics, potassium sparing. These corticosteroids, amphotericin. Sodium is controlled mostly extracellular. So it is in the extracellular, the important regulating amount and distribution of water. Sodium results in water retention. Excess sodium retention, water retention. Too little sodium may result in neuromuscular dysfunction. Total body sodium depends on amount of ingestion and renal excretion. The concentration of sodium in the body depends on amount of total body water. Non-renal in sweat and feces is small but is significant. Sodium intake is low. High sodium intake stimulates hypothalamus and generate thirst. Addition of salt to the food, consumption of high sodium foods depends on dietary habits. Sodium excretion. Sodium is filtered by freely through the glomerular filtration of the kidney. So filter depends on plasma. Sodium 65% filtered in the passively reabsorbed in the proximal convoluted tubule. And remedy actually reabsorbed by sodium potassium pump in ascending loop of Henle. So passive in the proximal convoluted and active reabsorption occurs with sodium potassium pump in ascending loop of Henle. Antibiotic can respond to plasma osmolality, acts on the increased water absorption in the distal nephron. Fluid movement across the capillary membrane. The capillary barrier is readily permeable to ions but impermeable to proteins. So plasma proteins determine the oncotic pressure. Albumin accounts for 75%. The capillary is site of fluid solute exchange between the incision of tissue and the bloodstream. Areolas become meta-areolars and then capillary bed. The flow each regulated by precapillary sphincter and flow. Capillary is a single layer of endothelial cells. These are potential osmotic pressure. Osmotic forms of diffusion of water molecule across the semipermeable when there is different concentration gradient. This is because number of concentrated particles in solution either side of the membrane generates osmotic pressure. Water is drawn by osmotic pressure moving from the regions of low osmotic pressure to regions of high osmotic pressure. Osmotic pressure is generated by the ions, sodium or chloride or by proteins. Capillary osmotic pressure refers to the oncotic plasma protein that is inside the capillary, sometimes called as colloid osmotic pressure or oncotic pressure. Tissue osmotic pressure is generated by the interstitial fluid. This is by the interstitial fluid. Hydrostatic pressure, difference between the capillary pressure, perfusion pressure generated by the blood pressure and interstitial fluid within the tissues. Capillary hydrostatic pressure, that is hydrostatic pressure. So capillary hydrostatic pressure, it pushes tissue hydrostatic pressure, capillary oncotic pressure, that is acting on this. So how is the arterial and venous end hydrostatic pressure is high, venous and hydrostatic, so fluid absorbed into the capillaries, fluids are pushed from the capillaries, net filtration out of capillary. Movement of fluid across the Starling hypothesis, distribution extracellular fluid between plasma and interstitial fluid is regulated by membrane of the capillaries and are lymphatics. The movement of fluid at the capillary membrane is shown the normal tissue that have few proteins in the interstitial capillary is impermeable to plasma, and so that osmotic pressure considered to be constant. In addition to the tissue hydrostatic pressure is relatively constant, capillary hydrostatic pressure is high at arterial end, favoring net filtration of the fluid into stadium. As there tends to be net flow of water out of capillaries into stadium at the arterial end and capillaries network. Starling is the movement of the fluid across the capillaries. K is outward pressure, minus inward pressure, and K filtration constant capillary pressure. Describes the clinical observation of excess fluid, tissue fluid. It is interstitial fluid. Cause edema includes increased capillary hydrostatic pressure, venous obstruction, decreased oncotic pressure, hypoproteinemia, increased obstruction, decreased oncotic pressure, increased oncotic pressure. Increased oncotic pressure resulting from the capillary permeability burns, decreased hydrostatic pressure in shock. So fluid requirements, daily sodium, potassium, average sodium required is 70 to 140. It is 1 to 2 per kg millimoles. So it is around 1. This is 70. This is 140. Chloride is again equal to potassium. Phosphate is around 0.2. You can see 0.1. It's just matching with the 7. This is all 0.1, 0.1, 0.2. Calcium, magnesium 0.1, 0.1. And 1 is potassium, 1 to 2 is sodium. So water requirement is around 2500 ml total. So how you make up? By drinking, by food and metabolic. And output is around equal. Fever increases maintenance fluid requirement by 20% of the daily insensible loss. 1% degree is lost, so you require more water whenever a person gets fever. In general, fluid maintenance needs to be gauged by measurement of adequate urine output. It has to be 0.5 ml per kg in the adults and 1 ml for that. Daily GI secretions, if you measure, is saliva is having 1500 ml, stomach's 1500 ml, duodenum, ileum is 3 liters, colon and bile is less. So maximum potassium is secreted in colon as well as in saliva, and maximum chlorides from here, and bicarbonates are lost from pancreas and bile. Patient size, ongoing losses, renal cardiovascular function, fluid loss, surgical trauma. What happens whenever there is trauma? There is antidiuretic hormone. Trauma, ADH release. Antidiuretic hormone release from the, it is also called as vasopressin. It is from the posterior pituitary. Release and aldosterone from adrenal gland, antidiuretic hormone and aldosterone. What they cause? They conserve water, conserve sodium and excrete potassium. Perioperative fluid balance must carefully be monitored in electrolytes. Source of excess fluid loss in the surgical patient is either blood loss, burns in plasma, GI vomiting, diarrhea, ileostomy, intra-abdominal fluid losses, pancreatitis, abdominal sensory fever and all this. It is so what you are getting, it is essential for accurate fluid chart to be kept. This records all fluid intake, oral as well as IV, and all output, urine, drain and GI content in 24 hours. So fluid depletion has to be tested by history if the person is very much thirsty, fluid intake and fluid output charts and fluid balance. Examination, mucous membranes, capillary filling time, sunken eyes, skin elasticity, low urine output, heart rate and blood pressure. Routes of fluid replacement, either you can give by oral fluids in say if GI is functioning, or you can give parenteral fluid, GI tract is not functioning. Replacement of parenteral fluid divided into crystalloid, colloid in blood. Fluid administration types is water. 5% water. How water is provided? 5% dextrose solution gives water. Dextrose is monomer and metabolized leaving pure water. Crystalloid solutions are physiological saline, that is 0.9, 154 sodium and 154 chloride. Dextrose contains calorific requirement negligible. Dextrose saline, they have contained 30 sodium, 30 chloride. Hartmann solution, 139 sodium and 29 bicarbonate, 111 chlorides. Ringer lactate, same, just colloid solution, albumin, blood products, no chloride. Limited accessibility, hemaxyl, gelatins, half-life is low. Dextra, glucose polymers. 40 is filtered by kidney, but dextran 90 not stay in circulation for longer time. Hetacyl starch, it acts for 24 hours. Use of common fluids. So what is there? This is the basic requirements. If you can see, basal requirement made a 70 kg adult man 1 liter of physiological saline. This are written when it is 500 ml point. So it 8 hours. One liter physiological saline, you add potassium 20 for first 8 hours. Then you give 1 liter of dextrose. Then add potassium 20, 20, 20. You supplement 20, 20, 20 potassium. 1 liter normal saline dextrose. Another regime is that 1 liter dextrose plus potassium for 8 hours. That is dextrose saline. That is called as dextro normal saline. So roughly 3 liters has to be provided. Correction of pre-existing diarrhea patients may need. First 24 hours no need of potassium. First 24 hours a non-cardiac potassium often omitted in IV fluid, and there is tendency of potassium to rise during after surgery because of cell injury, blood transfusions, stress hormones, insulin. So potassium is initially not required. It is essential to accurately fluid channels to be kept. So biochemistry, now coming to acid-base balance. If pH is less than 7.35, alkalemia, acidemia. So normal physiological depends upon pH, and major product of metabolism is carbon dioxide and organic acids. The body fluids pH stays from. Products of metabolism, CO2 and maintenance of the important. Acid is a proton pump or hydrogen ion donor. An acid is proton or hydrogen ion donor. It donates hydrogen ion. Alkali is hydrogen ion acceptor. Acidemia is increase hydrogen ions or it is decrease pH. Alkalemia is decrease hydrogen ions or increase pH. As to the abnormal condition demonstrated by decrease arterial pH. That is what it is, arterial pH. Alkalosis is abnormal condition demonstrated by increase arterial pH. pH is a logarithm to the base or reciprocal of hydrogen ions. Log of base of hydrogen ions. So it is very inverse. That's why hydrogen ion increase, pH decreases. This is why it is opposite. This resist changes in pH because of any acid reacts with free base and moves to left to provide base ion for the intercellular proteins. Phosphate acts as a buffers. Now what happens? Proteins and buffers act. Phosphate act buffer. Extracellularly, this is intracellular buffer, and this is extracellular buffer. Bicarbonate is a buffer system. Henderson-Hasselbalch equation. Intracellular protein phosphate, extracellular bicarbonate. What does Henderson-Hasselbalch says? Between carbon dioxide and bicarbonate, what happens? Carbonic acid converts into hydrogen ion and bicarbonate ions. The carbonic acid dissociates in the blood to form carbon dioxide and water. So carbon dioxide dissociates into water and bicarbonates. Therefore, carbon dioxide plus water, it is interchangeable. CO2 plus water, H2CO2 bicarbonate. In addition of acid, will shift this equation to the left and provide replacement of bicarbonate for in this solution have been used to neutralize the acid. The addition of alkali will shift the equation to the right. So this is shift to right, this is shift to the left, means in addition of acid will shift the equation to the left to provide replacement of bicarbonate ions for this solution have been used to neutralize acid. So addition of alkali will shift the equation to the right to provide hydrogen ions for this solution that have been used to neutralize the So if acids are added, it will shift to the left and bicarbonates are needed to be increased. The equation is given by This equation describes the relationship of arterial pH to bicarbonate and carbon dioxide. It is derived from the reaction of CO2 with water. So carbon dioxide with water, they will form carbonic acid, and which can be hydrogen ions plus bicarbonate ions. The carbonic acid expresses CO2, thus pH is or pK. This buffer system aims to minimize pH change. So if PCO2 goes up, then bicarbonate goes down, and if PCO2 goes down, bicarbonate goes up. Carbonic acid is not bicarbonate. If PCO2 goes up, then carbonic acid goes bicarbonate. The bicarbonate buffer system will not restore changes in pH. Excess hydrogen and bicarbonate ions are excreted over lungs and kidneys. Excretion via lung. What happens? A respiratory mechanism is a rapid response system that allows CO2 to be transferred from pulmonary venous blood to alveolar gas, and excreting brain stem respiratory center directly respond to levels of CO2 by detecting in the blood. So brain stem respiratory system detects hydrogen ions in the blood and they act. High levels of hydrogen ions causes increased rate of respiration, blowing out of CO2, thus decreasing acidity. Dysfunction of mechanics or control of ventilation can lead to retention and rise in hydrogen and respiratory acidosis, or over excretion of carbonic CO2 and fall excretion of kidney. Excess of acids and alkalis occurs slowly by renal compensation. The body produces more acids than base each day, so urine is usually acidic. It relies on the excretion of hydrogen ions, urine by secretion of hydrogen ions in the distal nephron. In addition, bicarbonate ions are generated in renal tubules. Renal dysfunction prevents hydrogen excretion, resulting in metabolic acidosis. The excretion of excess acid requires buffer system in the urine. The phosphates and ammonia are the buffer system. So respiratory acidosis results in primary disturbance of increased PCO2, leading to decreased pH and compensatory increased bicarbonates. Causes of respiratory acidosis: depression, respiratory center, either by some drugs like or CVA or any opioids that causes respiratory center depression, drugs, sedative, dizzying, chest wall movements, trauma, lung disease, COPD. All these causes decrease CO2. It is retention, and that leads to increased pH, and that decreases bicarbonate. Respiratory alcoholism results from predominant disturbance of the decreased PO2, leading to increase in pH and compensatory decrease. Causes of respiratory alcoholism: hyperstimulation respiratory center, CNS, encephalitis, hypermetabolic state, fever, sepsis, exercise, and excess ventilation, anxiety. Drugs like aspirin, they leads to washout of carbon dioxide, and that leads to fall in pH and leads to alkalosis. That is called as respiratory. Now, metabolic acidosis results from primary disturbance of decreased bicarbonates or increased hydrogen ion, leading to decrease in pH and compensatory decrease in PCO2. So what happens in metabolic acidosis? Increase anion gap. In another source is an acid source of production. Anion gap in renal failure, salicylate overdose, lactic acidosis, ketoacidosis, renal tubular acidosis. All these leads to increased anion gap, and that leads to metabolic acidosis. To overcome this, the respiratory mechanism comes in, and it tries to wash out. So diabetic ketoacidosis, renal ketoacidosis, and all this respiratory rate increases. Metabolic alcoholism occurs in diarrhea, fistula, where you lost the bicarbonates. Proximal tubular acidosis results from primary disturbance of increased bicarbonate, decrease in serotonin, leads to increase in pH and compensatory increase in PCO2. So increased acid loss, either vomiting, diarrhea, alkali abuse, urine acidification, diuretics, these all may lead to compensation in the acid-base balance. During disturbance in acid-base status, there is attempt of the body try to correct the disturbance. There are two mechanisms. Manipulation of PCO2 by respiratory is rapid but not as effective as renal mechanism. Manipulation of bicarbonate by the kidney is slow but more effective. Note, the compensatory does not bring pH to the normal. This is important. Compensatory mechanism does not bring to normal. They simply change the pH towards the normal. If pH is 7.35 to 7.45, if it has gone up, it will try to bring it towards. If it has gone down, it will try to bring it down. If acidosis is there, it will try to bring it. So bicarbonates will increase, but pH will not become normal. Interpretation of acid-base balance. So changes. From Anderson, it's seen that if the patient has change in acid-base status, three parameters change: pH, bicarbonate, PCO2. So A, B, C. acid alkali, bicarbonate, and PCO2. Blood gas machines pressure PO2 machines measure blood gas machines measure PO2, pH, PCO2 directly. Bicarbonate is calculated from Henderson equation. Other example variables in blood machine include actual bicarbonate. The concentration bicarbonate measured in the blood sample at standard bicarbonate concentration in blood sample is normal if there is no respiratory disturbance. Therefore, this equation remains about metabolic changes. Normal standard bicarbonate 20 to 26. More than 26 will be metabolic alkalosis. Less than 22 is acidosis. Normal arterial blood gas pictures will be pH 7.52, hydrogen ions is the partial pressure of oxygen is to be 10 to 14 or it will be 75, and carbon dioxide is 4 to 6, bicarbonate is 22 to 26. Interpretation of ABG. When interpreting arterial blood gas, it helps to logical scheme seen one below. Is patient hypoxic? If it is less than, PO2 is less, respiratory failure. How much inspired oxygen is on? How much oxygen is patient on? Now second is alcoholic or acidotic. pH. Normal pH, acidotic, alcoholic. Is primary disturbance respiratory or metabolic? Look at PCO2. So hypoxic, whether patient is hypoxic, alcoholic, acidotic, or look at PO2 and bicarbonate. Respiratory, PCO2 increases acidosis, decrease in alkalosis. Metabolic, bicarbonate changes. A respiratory disturbance, so this is important. A respiratory disturbance alters arterial PCO2, metabolic disturbance bicarbonates. So respiratory acidosis, increase CO2, increase carbonic acid remains unless there is metabolic compensation. When carbonic acid increases as it retained by the kidneys. Metabolic acidosis, decrease bicarbonates leads to decrease PCO2. Respiratory alkalosis, decrease. Compensation occurs within two systems when pH becomes disturbed. This rapidly occurs in respiratory system, changes to blow off. The kidney is metabolic compensation, responds slowly, approximately 4 hours, maximum compensation 4 days. So anion gap. Anions is the difference between anions and anions are chlorides and bicarbonates. Cations are sodium and potassium. The difference between them is calculating the anion gap. So you get total sodium, potassium on one side, it is 145. Chlorides and bicarbonates one side is 1. The anion gap is 10. If anion gap increases, it is metabolic acidosis. Metabolic response to surgery. Trauma can be defined as stress to the body. This provokes locally inflammation. There can be catabolic and anabolic status. The stress provokes metabolic response by injury, sepsis, dehydration, all these psychological stress, degree of trauma, sepsis, ebb and flow phase. There are so many phases in trauma. Ebb phase is less than 24 hours. Proactive mechanism, decrease proactive mechanism conserving circulating volume and minimize demand of the oxygen. That decrease oxygen consumption. So these catecholamines, cortisol, aldosterone, all they decrease oxygen consumption, enzyme action, decrease cardiac output, body temperature, acute phase proteins are increased. Then this is flow phase, hypermetabolic. First is ebb phase. This is all it is depressed. Then glucagon, insulin, cortisol, all they come in action. Then they increase oxygen consumption, glucose production, carbon metabolic rate. Then anabolic phase, 10 to 60 days tissue repair is there. Glucose is released from the air by glycolysis. Glycogen seriously ill patients. Fat is released from interleukins. Proteins are also muscle loss of proteins, severe loss of muscle proteins. Glucose is important in trauma and metabolic states and 70% glucose. Management of metabolic response, minimal insult if possible, minimal excess surgery, aggressive fluids and electrolyte to prevent decrease in tissue perfusion, provide sufficient oxygen, respiratory support has to be control glucose levels, control pain, manage body temperatures, avoid sepsis, production and utilization of energy patient. Energy produced from category food, yes. Energy is necessary synthesis. It is produced, energy is produced for heat. So 1 kilocalorie of the heat is regulated 1 kilogram of water. Energy is measured in joules, calories. The essential measurements of the heat is energy supplied by the different food is 1 gram of carbohydrate gives 4.1 kilocalories, 1 gram of proteins gives 5 kilocalories, and 1 gram of fat gives 9 kilocalories. So this is the energy production by the body can be measured directly, indirectly. Direct calories relies on measurement of heat released by the body. This is difficult to do so remains experimental. The indirect calorie measurement, the respiratory quotient is the ratio of oxygen consumption to the volume of carbon dioxide produced per unit of time. It reflects the fuel used to produce energy. Basal metabolic rate is the minimum calorie requirement to sustain the life. It is measured in kilocalories. BMR is measured in kilocalories per meter square per hour. How is BMR is measured? Kilocalorie per meter square, 35 to the energy requirement is about 35 to 40 kilocalorie per meter square per hour for adult male. So calorie requirement can be estimated by the equation 20 kilocalorie for 1 kg per hour. So BMR is equal to weight into 20. It is around for one. Around 20 kg required to maintain 1 kg body. Thus, for example, 70 will require baseline of 14 kg. The energy required for external were not taken. BMR is injuries. Factors affecting BMR. Height, tall persons have increased beta metabolism, surface area. Sex is decreased in females. Race, white has got more. Growth of the children require more BMR. Pyrexia, malnutrition, foods, hormones. T3, T4, all they decrease BMR. Stress increases BMR. Exercise increases BMR. Body temperature control is essential optimal functioning of intestinal aberrations in normal body temperature of compromised function. Body temperature control by balancing heat production against the heat loss. The body mechanism the increasing normal temperature actually ranges from 36 to 37 oscillates minimally between set point determined by the hypothalamus. Pyrexia is the temperature more than 37, hypothermia is less than 36. Physiological control of body temperature, deep tissues or body core temperature through the skin, climate versus climate. Heat production is essential by product of metabolism, so rate of production is determined by metabolic rates. Most of the heat is produced by the deep tissue such as liver and all. The production of heat requires oxygen consumption, and thermoneutral zone is temperature at which oxygen requirement for the temperature regulation is minimal. Nursing neonates raise temperature when body is cold. Elevation temperature in the body is cold achieved by cutaneous vasoconstriction. First is cutaneous piloerection, body temperature is increased production by shivering, sympathetic excitation, thyroid secretion, brown fat heating, and behavioral modification, clothing and all that. Heat loss from the body core, it is produced by two factors, insulation, fat conducts heat, and only third as well as other tissues and insulators. Cutaneous blood vessels penetrate fat and skin continuously. The rate of blood flow from the core to the periphery is controlled by sympathetic vasoconstriction, and dilatation of the vessels vary from. So as each liter of the blood 1 degree vasoconstriction causes conserved heat, and loss of heat. Radiation of an ambient temperature, conduction of the heat is motion, moving, wind chill. Insulator layer cannot form water molecules. So ambient heated by the body to form insulator zones. Vasculature is fully dilated, and then temperature has to be 30. The amount of water sweating. Heat loss from the skin is radiation, conduction, evaporation. So this is the physiology of abnormal body temperature. Pyrexia, what happens? There is toxins, infection they cause. Pyrexia release damage to the hypothalamus. Toxins, pyrexia set point of the hypothalamus to rise. Initially brings heat conserving mechanism, then interleukins raises. Heat stroke occurs if the environment conditions sufficient heat loss and convection, dizziness, and all these can be seen. When the core temperature falls up to 30 degrees, it is severe hypothermia, and hypothalamus regular temperature is lost and may lead to loss of consciousness and coma and depressed activity. Seen as trauma patient after pyrexia, blood picture first loss of control thermia due to drugs, volatile. These are relevant during depression. Fentanyl in opiates cause depression, regulatory neuromuscular blockade comprising shivering and hypothermia, autosomal dominant skeletal muscle, propofol, vasodilation, fentanyl, neuromuscular blockade, shivering. Levels, structure, critical levels, normal ward, increase ice, increase case, nurse patient ratio. And what are the different levels of critical care considered? Post-operative monitoring, it is necessary to consider what level of care of the patient is monitoring. Critical care provides 4 levels. Level 1 normal level, level 2 enhanced recovery. Nurse patient ratio has to be 3:1. High dependency unit nurse patient ratio is 3:2. Single organ failure not ventilated. If intensive care nurse patient ratio is 1:1, multi-organ failure. So recovery units is the level. So level 3 is enhanced nurse patient ratio. After general anesthesia, patients routinely transferred to recovery unit that provide level 3 critical care. So it is level 3 means very higher 1:1. The recovery unit produce continued invasive monitoring, detection of the continuous effects of anesthesia, and criteria to discharge to the world. Spontaneous area maintenance, awake and drowsy, comfortable, pain-free, no hemorrhage. High dependency unit HDU provides level 2 grade care for patients who require more input in general ward, can give single organ failure, do not require ITU or then intensive therapy unit again level 3. ITU beds in the UK account for 1% of the total ITU beds and 4 beds to be sufficient. Minimum should have. They often have 80 12, but bed occupancy is 70%. ITU should ideally be near on same floor and theaters. Admission to ITU for elective emergency prophylactic treatment, potential reversible conditions or specified high level of monitoring is required. Mechanical support is required. Discharge from the ITU, discharge to high dependency unit, general ward or patient, staffing critical, medical staff, special training, intensive care medicines. Intensive care require a basic specialty for anesthesia, medicine, surgery. The units all daytime 24-hour dedication. SHOs fellow from other specialties, 3 months training in ITU. Rationale for critical care, reasons for poor outcome in critical care, inadequacy ward, late referral to ITU, cardiac arrest. Improvement in survival is possible because earlier critical care intervention, better training of the medical nursing scoring system, critical early warning and scoring system. These are needed to recognize ill patients on the ward and institute critical care. The airway compromise, respiratory rate, oxygen saturation, heart rate output. Examples for early warning signs. Many hospitals use medical early warning signs. MUSE. What is MUSE? Medical Early Warning Sign Systems. In order to identify the critical care patients, highlight deterioration of various stable patients. The MUSE system converts vital signs and numerical scores. Nursing staff has set a threshold at which doctor must be called. MUSE scores taken into consideration to hemodynamic parameters, temperature, urine output, respiratory rate, level of consciousness. So what they pulsed BP, temperature, urine output, respiratory rate, level of consciousness. Scoring system enables comparison between the units. Existing difference. Average mortality rate in ITU is 20-30%. Standardized mortality SMR calculated unit of domestic acute physiological 3-point scoring system, physiological based on Glasgow urine simplified physiological score. Injuries anatomical scoring up to 5 to 10. Revised trauma scale where TRIS normalize therapeutic interventions question. Transportation of critically ill patient. Standard care provider must be same that a patient must be transported adequately, stable, secure airway, IV access, qualified staff. So this was about critical care.